Hello, this is Dr. Marilyn. The title of this presentation is Fundamentals of Bone Tumor Pathology. I would like to thank Dr. Raj Singh for this opportunity to record this lecture. I am a senior member and a professor of pathology. I'm the section head of bone and soft tissue pathology at Moffitt Cancer Center in Tampa, Florida, United States. Moffitt Cancer Center is the third busiest cancer center in US. Even bone and soft tissue tumor is very rare. It's composed of 1% of all tumors. Sarcoma is not rare in Moffitt. For example, every Thursday, I will go to multidisciplinary conference to present the sarcoma cases. Typically, we present and discuss 30 to 40 patients. So I'm practicing bone soft tissue pathology for 15 years now. In addition, I do cytopathology and digital pathology. As you know, that a patient's medical journey begins with their diagnosis. Pathologists provide forecast of diagnosis, prognosis, and predictive information for therapy. So that put pathologists in a really strategic position. We are positioned as the natural leaders of precision medicine. In the multidisciplinary care team, it is very important to collaborate between pathology, radiology, surgery, oncology, and other clinical team members. It is also important to practice medicine following the standardized guidelines. This is also true for managing and diagnose bone tumors. What is the basic approach for a pathologist to render a definitive diagnosis for bone tumor? When we're in medical school, we learned as a clinician, we do three things. We take a three-step approach. First, take chief complaints clinical history. Second, do a physical examination to verify the symptoms and presentations. Third, we perform ancillary testings to verify and confirm our working diagnosis. For pathologists, we do something very similar. We first take clinical histories by examining the notes in the electronic health record or the notes put down on the surgical specimen requisition to get the clinical information. In this case, the radiology notes is also a part of clinical history. So we understand what is the working diagnosis the clinicians have and what do they want from us, a pathologist. Second, we'll examine the specimen, including gross examination, frozen section, we do the fine needles, and also examine the slides under microscope. The type of slides we examine are mainly HE slides. In addition to that, we will perform ancillary testing, including the special chemistry stains, immunohistochemistry, molecular testing, and other genomic testings. So once we take those three steps, that will help us to get to a diagnosis. So as a bone and soft tissue pathologist, when we receive a case or sample, we first ask ourselves the question, is this a tumor or not tumor? If it's a tumor that is neoplastic, then we ask ourselves the question, is this benign or malignant? Benign tumors will not cause a severe problem with the patients, usually either observe or resection, but malignant tumors are a lot more aggressive, will be causing metastatic tumor and also cause death in the long run in the patient. So if it's a malignant, and our first question is, Is this a sarcoma, that means bone and soft tissue, mesenchymal tumor, or a non-sarcoma? Because the treatment for those tumors are very different. For example, if you get called for a frozen section because the patient has pathologic fracture, the surgeons want to know, is this a sarcoma or not sarcoma? If it's not a sarcoma, it is metastatic carcinoma, lymphoma, or melanoma, they will fix the fracture by intramedullary rod. However, if it's a sarcoma, that practice is not indicated because you will help to spread the sarcoma into the other part of the body. So if you put a rod in a sarcoma patient, that is malpractice. So it is very important to know sarcoma versus non-sarcoma when you do a frozen section. So once you decide it is a malignant mesenchymal tumor sarcoma, then you're trying to figure out what type. So the tumor class, we're using the WHO classification. It's classified into 12 groups. And then we will further decide, is this a high-grade or low-grade tumor? Low-grade tumor is usually treated by surgery. High-grade tumor, especially if there's a metastasis, probably require chemotherapy. So what are the tools in our toolbox for pathologists to render a definitive diagnosis? So there are some resources that are listed here. They are textbooks. The very first one is the WHO classification of tumor of soft tissue and bone. This is the 2013 version. In a couple of months, there will be a brand new version coming out. But the basic information for the purpose of residence fellows, this lecture will still be good. So I highly recommend you get a hold of a copy of WHO classification of sarcomas, because this book is very concise, list the clinical information, pathogenesis, histology, growth, radiation, differential diagnosis, and prognosis. So that's a must-have book. The second book is a much bigger textbook with pretty comprehensive information. As a bone soft tissue pathologist, I use this book for references, but usually it's not practical to read this type of book from cover to cover. So when we look at the tumors, as we said, there are 12 classes depending on the histiocytic lineage. However, when the tumor comes in, they don't tell you, oh, I am of osteoid origin. Oh, I am a fibrotic tumor. They will come in, show you different morphology. So how do we use the tumor morphology to get into the tumor class, eventually get to the specific diagnosis? So that's a very important approach. That means using a morphologic approach. So that's why my co-author and I, we produced this book called Atlas of Soft Tissue and Bone Pathology. So this is the intention is to serve as a scope side diagnostic companion. So if you can figure out this is a spindle cell tumor, probably it's a fibrous origin, and probably it's low grade, then we will have a chapter to show you what are the common differential diagnoses, and then we describe each one, and to give you a good concept, how are you going to triage the case so you can do the appropriate ancillary testing, correlate with the clinical radiological information, and lead you to the right path to get a correct diagnosis. So after you're done with the diagnosis, and of course, we'll do the tumor staging, and we'll use the AJCC cancer staging book. So those are the basic tools in our toolbox. But there are some more dynamic documents are the guidelines. So here in this slide, we're showing there are certain guidelines we're going to follow for pathologists the College of American Pathologists Cancer Protocol for bone tumor is really relevant for us. And for the clinicians, there are practicing guidelines. For example, NCI-NIH Cancer Center has this bone sarcoma guidelines, and our European colleagues also has clinical guidelines. So what do pathologists do with each bone tumor diagnosis? For first of all, I want to emphasize that there is a shortage of pathologists. As you may know, in the publication listed on the right, there is approximately 18% decrease in pathologists in US. However, there is an increase, approximately 42% of the demand of diagnostic need for pathologists because of the precision medicine, targeted therapy, immunotherapy. Let me explain to you why. So when we talk about pathology, we immediately focusing on diagnosis. Yes, it's very true for bone tumor. We need to give a diagnosis which is based on the histological type. At the same time, we need to grade the tumor because the tumor grade determines the biological potential. We also need to do the pathologic staging. And also the tumor can be treated by surgery. After the surgery, the pathologist's job is to confirm the tumor type, do the tumor grade, do the staging, but most importantly, decide what's the surgical margin. And also, if the tumor is treated with a neoadjuvant chemotherapy or radiation therapy, then pathologist's job is to evaluate the therapy effect. So what is really make things more complicated comparing to what pathologist's job before is to study and identify molecular, genomic, immunohistochemical biomarkers. Because right now, even for cancers like lung cancer, used to be small cell, non-small cell carcinoma, period. Now, you have small cell, non-small cell. Within the non-small cell, you have adeno, squamous, and then you have all those immunomarkers. So for the same number of case, the task you're doing for this one case is just exploded. So that's why we're getting busier. For sarcoma, it's the same way. It's no longer just look at the morphology, trying to make diagnosis. We have to do multiple immunostains, molecular testing, next-gen sequencing, and all that to provide diagnostic, prognostic, and predictive information. So after all this work is done, and all our decisions is translated into a pathology report. So how to communicate what you have in mind? Just by clicking the send to release the pathology report is not sufficient. We need to have this very effective and clear communication with a multidisciplinary team. For example, if I did a resection specimen and I found positive margins before I finalized the case, I will send an email to the surgeon and say, oh, you have a positive margin. So the surgeon will respond to me, said, oh, that's okay, not a surprise, because this tumor was sitting on a big nerve or a big vessel, or just there's no room for me to operate. So I accept a positive margin because I can treat and clean that area with radiation. So that's scenario number one. Scenario number two, the surgeon will say, oh, that's a surprise. Can you tell me more about how did you reach that positive margin diagnosis? And I will email the gross picture and microscopic picture to them, or they will come over before the COVID-19 to my office to look at the microscopic image or the gross image. Then we'll decide, oh yes, it is still a positive margin, but don't worry, we can take care of it by radiation. The third scenario is they go like, I am really surprised. Even after we look at everything, it's still not convinced. Sometimes we may strip off the capsule of the tumor and the ink went into the deeper tissue, create a positive margin. And then we can put our heads together and said, okay, oops, pathology department artificially created positive margin, scratch that. So I will sign out the report as negative margin. So that type of communication is very important. So let's talk about bone sarcoma. So as we said, it's a very rare tumor. So bone and soft tissue tumor accounts for 1% of all tumors. And the sarcoma is even more rare. In soft tissue, if you see 100 benign soft tissue tumors before you see one sarcoma. So for bone sarcoma, there are some common ones. For example, osteosarcoma, chondrosarcoma, Ewing sarcoma, chordoma, and undifferentiated polymorphic sarcoma. UPS is a diagnosis of exclusion. So if we are accurate in putting the tumor into the right category, and then we don't end up with a lot of UPS. So let's look at osteosarcoma. This is the #1 primary bone tumor. So mostly in young patient, teenagers, or college student. That's one pick. The second pick is older patients when they are 50, 60, 70, and 80. And they can be de novo, but it can also be secondary. For example, the patient has Paget's disease of bone, or the patient had radiation therapy. So that's osteosarcoma. Second common one is a chondrosarcoma. You can see chondrosarcoma is older person's disease. Usually it's in patient 40 years or even older. Most of them is a 60, 70 year group. So you see the patient profile is very different. Third tumor is Ewing sarcoma. Ewing sarcoma is also in young patients. As you know, Ewing sarcoma belongs to this blue round cell malignant group. Then the differential should include lymphoma, plasmacytoma, because they could occur in young patients too. So chordoma is rare. So chordoma is mainly in older patients. See, for the osteosarcoma, chondrosarcoma, and the Ewing sarcoma, they can occur in long bones, flat bones. And for chordoma, has very specific location, especially we're going to talk about it in that section particularly. So please pay attention to the specific location. And the UPS, as we said, is rare. It's diagnosis of exclusion. So this shows what's the most common bone tumor types and the location. So let's review the normal anatomy of bone. So this is a long bone. This is the proximal epiphysis area. This is the metaphysis area. This is diaphysis. This is the distal metaphysis epiphysis. So what we're looking here is cortex within its medullary cavity. So this is an image, I got it from Amazon.com. So this is an image, credit goes to here. It's showing the most common tumor types and the location. I want to draw your attention to this area, what we call the epiphysis metaphysis area. Giant cell tumor of bone lives in this area. Usually it's 30-some years old. Female more common than male. Chondroblastoma like to stay in this area too. And in the medullary cavity, and we will see in chondroma, that's a benign cartilage tumor. Osteosarcoma, that's malignant bone tumor producing bone. And the UPS stay in this area. And the Ewing sarcoma and the round cell tumor also like to be in medullary cavity. There are some tumor like to occur on the cortex. For example, osteochondroma. This looks like a mushroom herniation of a bone, has cartilage cap, and the medullary space kind of herniate out. So this is benign lesion. Aneurystic bone cyst can have the tendency to be at the cortex. Osteoma is a benign bone lesion, is at the cortex. Radiologically, it's very characteristic, has nidus, and the patients are usually young, has excruciating pain at night, and if they take aspirin, they will get better. So that's a benign lesion. And adamantinoma is an intermediate grade malignancy, has biphasic component with keratin positivity, and that's adamantinoma. And also, there are other lesions like a fibrous dysplasia. We're going to talk about it. And aneurystic bone cyst, osteoblastoma like to be in the medullary space. So that's some of the most common tumors and their location in a nutshell. So this bone tumor are arbitrarily divided into those 12 groups by their histiocytic lineage by the 2013 WHO. So be familiar with all the components is very important. For example, if you go to a restaurant to order food, but this is a brand new restaurant, you really don't know what is what. So be familiar with the menu, knowing what is in the vegetarian section, what's in the seafood section, what's in the beef section. You'll have a good idea of what you may like. So over here, when it is called a chondrogenic tumor, that means they're producing cartilage. Osteogenic, they're producing bone. Fibrogenic, producing fibers. And it's along the same line. Over here, the same logic. And the Ewing sarcoma has its own category. So when we say tumors, and there are 3 types of tumors are included. There are benign ones, there are malignant ones. Some of them has intermediate nature. That means they are locally aggressive. Some may be rarely metastatic. So malignant tumor, they metastasize, they're locally aggressive, they will cause death, and it's what we so-called sarcoma. So those types are all histologically type-based, but as we explained, the tumor don't come in and declare which class they belong to. They all coming in, and then we have to figure out what they are. So how do we figure out? So the parameters we're examining under the microscope, first is the cell morphology. Is this round cell? Is this spindle cell? Is this epithelioid? Is this giant? Is this small? That will help us to narrow down the differential diagnosis. The second thing we're looking for is what is the tumor producing? The stroma, the matrix. Say if they're making bone, so that's osteos lesion. So that go to chapter number 1. If they're making cartilage, then go to chapter number 2. Well, switched. Cartilage and the bone, chondrogenic, osteogenic. The second we're looking at is this benign or malignant by the differentiation, if there is any atypia, mitosis, necrosis. So we look at the nuclear features to evaluate the degree of differentiation. If the nuclear features is big, dark, and ugly in general, that means malignant. Big means increased NC ratio, dark means hyperchromasia, ugly means irregular nuclear contour or clumped chromatin. So most of the malignancies has that features, but there are certain tumors, they have this monotonous, low-grade look. Once we encounter those tumors, I will point it out. And with that, we will put the tumor into osseous, cartilage, giant cell, small cell, spindle cell, cystic, and epithelioid in all those categories to help us to narrow down the differential diagnosis, integrate IHC and molecular profile with this step-by-step approach will eventually render a definitive diagnosis. So now let's talk about the osteogenic group. The example we're using here is osteosarcoma. So this image is taken from the atlas. So look at over here, it's a skeletal immature patient. Why do we say it's immature? Because the plate is still open. And why do we call this is malignant? Because you can see over here, there is a tumor growing. This tumor has this permeative pattern. That means it's eating up the normal component and also went into the soft tissue already. Just by looking at this, we know this is malignant. And how do we know this is bone-producing malignancy? Over here, we have this cloud-like permeative matrix. So this is characteristic for bone-forming tumors. So in the eye of experienced surgeon and radiologist, they can tell you this is osteosarcoma. So another feature we're looking for to show the tumor is aggressive is this peri-osteo reaction. Over here is called Codman's triangle. You see, this is the cortex. This is the periosteum. It's lifted, causes this triangle. So with all this, the surgeon already know this 20 years old, when he was playing soccer, he fell, he fractured, and they did a radiology study. They found this mass. Both the radiologist and surgeon tell you, this is osteosarcoma. They're going to take patient to OR to do a frozen. Then they decide how to fix the patient and what to do next. So they will send a frozen section to you. And you look at this, has some bone fragments and has some tumor replacing the marrow space, and this tumor producing this immature bone called osteoid. When you go to high power view, we see all those malignant looking cells. They have big, dark, and ugly nuclei. So it's definitely malignant because they're producing this immature bone called osteoid. So this is a high-grade osteoblastic osteosarcoma. So once you made that diagnosis on frozen, so that the surgeons know to put a port on the patient, because the patient is going to be treated with neoadjuvant chemotherapy first before surgery. And that this pathologic fracture absolutely does not allow to put a rod, you have to fix around it. The fixation is very different from if it's a young patient has a lymphoma or metastatic carcinoma. So this is another type of osteosarcoma called chondroblastic osteosarcoma. You can still recognize this is osteosarcoma because you see the malignant cells, you see immature bone formation. But this time has a chondroblastic component. They are chondroid because they are making chondroid matrix, and the cells look like a cartilage, but they are malignant cartilage. So when you have this all together, and in a patient that is 40, 50 years of age, so it's diagnostic for chondroblastic osteosarcoma. So as you can see, this tumor, the differential diagnosis will be chondrosarcoma. I mean, chondrosarcoma shouldn't have this osteoid formation. So here is a table that is taken from a publication that is published by Dr. Jin Siegel and Dr. Shi Wei, who are a friend of mine. So they had a very nice summary of all the osteosarcomas. So the conventional osteosarcoma has osteoblastic, chondroblastic, and fibroblastic type. The medullary type of osteosarcoma has the conventional one and has giant cell ridge, telangiectatic, and small cell osteosarcoma. The giant cell ridge one has a lot of osteoclast type giant cells. The telangiectatic osteosarcoma is very hemorrhagic. In addition to the bone forming malignant cells, it has a lot of blood spaces separated by the fibrous septa. So the differential will be with the ABCs and aneurystic bone cyst. The small cell osteosarcoma has a lot of small blue round cell tumors. So the differential will be with Ewing sarcoma, but in this case, you can see osteoid formation, which is absent in Ewing sarcoma. And there are some surface osteosarcoma. Paraosteosarcoma is a low-grade bone-forming tumor. Periosteosarcoma is intermediate cartilage-forming osteosarcoma. And then there is also this high-grade surface bone sarcoma. So on the right, from the same authors, there are some summary of the differential diagnosis of osteosarcoma when you have time, and you can study each one of them. And the salient distinguishing features are listed on the third column. So now we're going to change gear to the chondroid tumor group. The big tumor in this group is a chondrosarcoma. Chondrosarcoma has conventional type, including primary and secondary variants and the periosteal type. In addition to the conventional chondrosarcoma, there is also dedifferentiated chondrosarcoma, mesenchymal chondrosarcoma, and clear cell chondrosarcoma. So here is an example of chondrosarcoma. First, we know this is malignant because the tumor replaced the medullary space, break the bone, went to the soft tissue. The reason we know this is chondrosarcoma because it's producing cartilage. So radiologists and surgeons will study this, and they already know this is chondrosarcoma. So they really don't need to do a biopsy to confirm it. So usually pathologists get a resection specimen. So our job is to decide the tumor type, tumor grade, and the tumor margin. So in this case, you can see the sample is very heterogeneous. Over here, you have a transition from benign cartilage to some low-grade cartilage. Over here, you have some low-grade to intermediate-grade cartilage, so that's a chondrosarcoma. And over here, there's no cartilage at all. It's an undifferentiated spindle cell malignancy. So if you just evaluate the sample on those two, you're going to call this chondrosarcoma. But once you have this dedifferentiated component, this particular sample is going to be labeled as dedifferentiated chondrosarcoma instead of conventional chondrosarcoma. So pathologist's job is to give the tumor type and also the tumor grade, because the histological grade is the single most important prognostic factor. For the most part, chondrosarcoma, it's a surgical disease. It's different from the osteosarcoma. For osteosarcoma, pathologists usually see the sample at the biopsy stage and then treat it with neoadjuvant chemotherapy, surgery, and the pathologist will see it again when it's resected to evaluate the therapy effect and the margin. And later, when the tumor metastasis, a pathologist will see it again to examine the metastasis. For chondrosarcoma now, pathologists first time seeing it usually is at a resection. Sometimes it gets biopsied, but not as often as the osteosarcoma. So our job is to evaluate the tumor type, tumor grade, and the margin. So the tumor grade for conventional ones has grade 1, 2, and 3. So I try to use the example of renal cell carcinoma grading to compare with the chondrosarcoma grading. Because for clear cell renal cell carcinoma, if you can see the nuclear polymorphism and the prominent nucleoli under low power, that's grade 3. That's also true for chondrosarcoma. And if you can see all that in the medium power, that's grade 2. And if you have to examine it under high power, they are still not hypercellular. There's not much nuclear atypia. And that's pretty much grade 1. So then you will ask, how do I differentiate grade 1 chondrosarcoma versus inchondroma? And I will explain to you in the next slides in the inchondroma slide. So let's continue talking about the other 2 variants of chondrosarcoma. The third variant is mesenchymal chondrosarcoma. You can tell this is the chondrosarcoma conventional chondrosarcoma component. Now there's this blue round cell component. So when you put this together, that's mesenchymal chondrosarcoma. From this slide, you can tell the differential will including Ewing sarcoma. Over here on the 4th panel has staghorn vascular channels. Then tumors such as a solitary fibrous tumor and the malignant peripheral nerve sheath tumors, synovial sarcoma, and all that could be introduced into differential diagnosis if the clinical setting suggests that. So the 4th type of chondrosarcoma is clear cell chondrosarcoma. Under low power, you can recognize the chondroid appearance because the cells has this rigid border, centrally located nuclei. They're malignant because the nuclear features are malignant. But those cells are very impressive with this abundant clear cytoplasm. In the right clinical setting, they could be the differential diagnosis with a clear cell sarcoma of renal primary or the other clear cell tumors. So that's a tumor that's worth mentioning. So let's talk about the inchondroma, which is a benign cartilage tumor. So first of all, how do radiologists recognize a tumor is producing cartilage? So this is the pattern of mineralization of cartilage. So 3 patterns: stippled, flocculent, ring, and arc. And this example here is flocculent and the ring and arc pattern of mineralization. When you see that, that's cartilage. So how does that correlate with the histology? So here is the benign cartilage. The arc is the bone that is being pushed on. And over here, it's the normal marrow spaces. And here, there is some other lobulated islands of cartilage. And in inchondroma, there is no permeation of bone. When the permeation happens, that is chondrosarcoma. But for low-grade chondrosarcoma, radiologically, sometimes they can erode into the cortex, and the radiological term is scalloping. Usually, if it's scalloping more than 2/3 of the cortex, most likely it's going to be a low-grade chondrosarcoma. So now we talk about bone two kinds of bone tumor, osteosarcoma and chondrosarcoma. So it's a good place to start to summarize what are the differential diagnoses for some surface-based bone tumors. So in this table taken from our book, included the periosteochondroma, paraosteosarcoma, periosteosteosarcoma, high-grade surface osteosarcoma, and periosteochondrosarcoma. So when you have time, please study those tables. It's self-explanatory. So now let's change a topic, talk about the Ewing sarcoma, which is the third common sarcoma. So this tumor usually is in young patient or very old patient. So in 60% of them involving the long bone, usually occurs diaphyseal, and it's lytic, blastic, and permeative pattern. And there's no matrix. The matrix is reserved for bone or cartilage tumor. So radiologically, you probably will see they describe Ewing sarcoma, use the term onion skin. So this describes what onion skin means. The onion skin periosteal reaction, sunburst. So you have this sunburst appearance. So this is frequently seen in Ewing sarcoma because Ewing sarcoma is such an aggressive tumor. But when you see this, it's not necessarily always Ewing sarcoma because osteosarcoma could have this pattern. So the deal breaker is to look for the matrix of osteosarcoma. So second clue for Ewing sarcoma is typically have very large soft tissue mass. And especially when they discovered the mass, it didn't really take long. It's already breaking the bone into the soft tissue. So large soft tissue unproportioned to the duration of disease and all that, it's a good indication for Ewing sarcoma. Ewing sarcoma histologically is a classic small blue round cell tumor. Characteristic immunohistochemistry including CD99, FLI1, and ERG. The hallmark genomic signature that is the driver of the disease is the translocation of 1122, where EWSR1 rearranged with FLI1 in 90% of the time, and sometimes also in ERG. So this molecular change can be detected by classic cytogenetics, also RT-PCR, but most frequently it can be done by fluorescein in situ hybridization. So this is a break apart strategy. The presence of a translocation is confirmed by the two separate signals. With a single signal, it's orange because red and green together is yellow-orange. When they break apart, they become the independent red and green signal. So this is a good place to talk about the differential round cell sarcoma diagnosis. So the big one is Ewing sarcoma. So we discussed the HE, IHC, and molecular signature. The second is mesenchymal chondrosarcoma, has this biphasic pattern, has small blue round cell tumor and well-differentiated hyaline cartilage. SOX10, SOX9 is positive, and there is a rearrangement of HEY1 and COA2. Small cell osteosarcoma has a various degree of osteoformation, and if it's a biopsy specimen and you're trying to highlight the bone folding features of this tumor, SET-B2, it's a good marker for this. So now let's change to the fourth type of sarcoma, chordoma. This tumor, you remember when we do the most common tumors, you didn't see it because it doesn't really occur in the extremity. Usually it occurs in the older patients, 50 or 70 years of age. The typical locations are base of skull, vertebrate bodies, and the sacrococcygeal bone. So this is a case of sacrococcygeal bone. So the histology has this lobular appearance, septed by the fibrous septa, has abundant myxoid stroma. So this is, we're talking about the extracellular. When you look at the cells, they have this round nuclei, abundant intracellular mucoid material, give this bubbly appearance. So it's described as a physalliferous cells. And this is a cytology and showing those very strikingly bubbly cytoplasm physalliferous cells. So the tumor cells has the characteristic immunostain pattern, positive for EMA, keratin, and 100, and the brachyury. So we talk about all those malignant tumors. Let's talk about giant cell tumor of bone. This is a locally aggressive tumor. Radiologically, it's very characteristic, as we talked before. It's located in the epiphyseal location, can go to metaphyseal area, has this very sclerotic border, locally aggressive. So this is the resection of the tumor, looks hemorrhagic, and has hemosiderin-laden macrophages, and they're locally aggressive, so they could, breaking the bone, extend into the soft tissue. So under the microscope, we see numerous multinucleated giant cells and the mononuclear cells. So it is important to point out those mononuclear cells are the neoplastic cells. They express rank ligand. And those multinucleated osteoclast-like giant cells are reactive in nature. So giant cell tumor, which is a differential diagnosis with the giant cell rich osteosarcoma and aneurystic bone cyst. It is important to recognize giant cell tumor and give it the definitive diagnosis because there's a new treatment. Before the treatment is curettage in block resections, so 50% of them come back. And then later on, the surgeons will do the curettage and do some adjuvant therapy, for example, do laser or cryo to burn that tumor bed. So we'll reduce some recurrence, but still they come back. And this is a benign, so-called benign tumor, but there is 2% will experiencing lung metastasis in 3 or 4 years. So the new treatment we're talking about is targeted to RANK ligand, and it's called denosumab. So this is the article published by Dr. Andrew Rosenberg in the group. It's talking about, look, this is the giant cell tumor of bone before the denosumab therapy. After it treated, guess what? The giant cell tumor, the giant cells disappeared. So has some osteoid formation. So this could cause a lot of confusion. If you go to do a frozen, the surgeon said, patient has history of giant cell tumor, tell me what is this? You look at it, look like kind of bone forming tumor, but if you have the history of targeted therapy, now you know this is a treated giant cell tumor of bone. Now let's talk about the fibrous dysplasia. For radiology, we talk about when it's bone, has a certain matrix pattern. When there's cartilage, there's a certain matrix pattern. Now we're talking about the third pattern, that is fibrous. The key word to describe a fibrous matrix is ground glass. So here we have a fibrous dysplasia, has this ground glass appearance. Usually occurs in metaphyseal or diaphyseal, and because this is a benign lesion, so it only expands the cortex. It has sclerotic, well-defined margins. They could chip into the cortex without breaking it. But when the bone keep getting weakened, so the bone will become deformed like this shepherd crook. And this is a very metabolically active tumor, so it's very hard on bone scan. Fibrous dysplasia is a key component of a McCune-Albright syndrome. When patients with this syndrome, there is a twofold increase in malignant transformation. So fibrous dysplasia will undergo malignant transformation. So within the McCune-Albright syndrome, there is a polystatic fibrous dysplasia, cafe au lait spot, something like this, and the endocrine abnormality. So fibrous dysplasia, usually radiologically, is pretty characteristic. So if they send a biopsy to pathologist, what we will see is this. So this is under the microscope, has this irregular bone spicules. In textbook, it's described as Chinese characters. See, the marrow within the bone is all lost, replaced by bland fibroblastic cells. They have this spindle cell stroma. So the pathogenesis of this tumor is caused by GNS gene mutation. GNS gene encodes G nucleotide binding protein alpha subunit. The post-zygotic activating missense mutation of GNS caused fibrous dysplasia. So let's talk about after chemotherapy, what do pathologists do to evaluate tumors like osteosarcoma, chondrosarcoma, or Ewing sarcoma? So we need to examine the entire tumor blocks to evaluate for percentage of necrosis, viable tumor cells. It is important because it has prognostic value. When the necrosis is less than 90%, the 10-year survival is 50%. What we want to do is to achieve greater than 90% tumor necrosis, then the 10-year survival is greater than 90%. So before the 70s, the only treatment for osteosarcoma is surgery, amputation. So 70% of the patient will die within 5-10 years. But after the chemotherapy become the standard of care, if the patient respond to therapy greater than 90%, most of the patient will live for a long time. So this is an improvement. So after we made the diagnosis, we're going to do the staging. The staging book is the AJCC 8th edition based on histological type, grade, size, location of the tumor, and the presence and the location of metastasis. So in this book, the tumor are grouped into 3 groups. The appendiceal, skeleton, trunk, skull, and facial bone is staged one way. The spine has its own way, and the pelvis is another way. In the primary bone sarcoma, grading is also important. So for the tumor that we mentioned above, so the grade 1s are osteosarcoma, grade 1 chondrosarcoma, low-grade intramedullary osteosarcoma, clear cell chondrosarcoma. See, even the clear cell looks so drastic and looks so bad. By behavior, they are low grade. Grade 2, including periosteal osteosarcoma, grade 2 chondrosarcoma, classic adenocarcinoma, and chordoma. So the high-grade tumors, as we mentioned, conventional osteosarcoma, UPS, Ewing sarcoma, grade 3 chondrosarcoma, D-differentiated chondrosarcoma, mesenchymal chondrosarcoma, and the D-differentiated chordoma are all high-grade. So how about the molecular pathology of tumors? So one point I like to make is if you're planning to do molecular testing for bone tumor, please save the tissue without decalcification, because decalcification will make the molecular testing not possible. So this article is published by a friend of mine, Dr. Andre Flanagan. They are located in London. So they did this comprehensive review, pointed out some of the molecular pathology in certain tumors, for example, giant cell tumor of bone, chondroblastoma, mesenchymal chondrosarcoma, chondromyxoid fibroma, aneurystic bone cyst, osteoblastoma, and also synovial chondromatosis. Also for central chondrosarcoma, and IDH1, IDH2 mutation is an important molecular driver. So for bone tumor, there are new treatment is coming into play now. Traditionally, treating tumor, it's just the surgery, radiation, chemotherapy. Surgery, radiation achieve local control, but doesn't really have impact on the disease survival and all that. The chemotherapy is systemic control. And when the tumor already in the blood, the systemic treatment can clean up all the tumor. But the chemotherapy, it's like a toxic, poisonous chemicals will kill both the tumor cells and normal cells. So it's really a brutal treatment. So that's why patients experience a lot of side effects. So with the molecular medicine study targeted driver for the diseases, and we have new therapy called targeted therapy. And then in addition to that, and we also have immunotherapy now. As you know, the cancer immunology, our body's immune system is supposed to recognize bone tumor as something wrong to fix it, but because of the change of the immune system, the body is not able to recognize. So the immunotherapy will wake the body up to recognize the bone tumor is foreign, start attacking it. So this is new immunotherapy is taking place. For example, there are opportunities for CAR T therapy. And also there are bone marrow transplant, and maybe there are some hormonal therapies for certain tumors. So those are the main therapeutic modalities. So as a pathologist, and we're going to help to triage the sample, so we're able to study them to identify the new targets for therapy later. So with that said, and we talk about the fundamentals of bone tumor pathology. If you have questions, please email me or send me through social media. So thank you very much for your attention. And as a pathologist, it's really exciting to practice pathology at the era of precision medicine. As you may know, we're experiencing the third revolution of pathology. Our profession was born when microscope was born, so we're able to examine the tissue under microscope with HE. The first revolution of pathology was IHC. With the IHC's help, we're able to study the proteins in the cell membrane, cytoplasm, or nuclei. So it will help us to decide what's the lineage, what's the primary site, and also identify prognostic predictive information. The second revolution was molecular pathology, next-gen sequencing, and the third revolution now is digital pathology and artificial intelligence. So in addition to bone soft tissue, as I said, I also do cytopathology. So we published a new book called Modern Techniques in Cytopathology. As you can see, molecular pathology, digital pathology are all mentioned in there. And also I like to mention this book called The Healing Art of Pathology, because I love what I do for pathology. I know our job is very important. So I'm trying to use this book to connect pathology with the patients and then with the publics to recognize the talent, the passion, the people behind the microscope. So check all those out. Most importantly, I like to mention Digital Pathology Association, where you can join as a member, especially if you are a residence fellow. The membership is complimentary. Once you join the membership, you're able to access Digital Pathology Association's Digital Anatomic Pathology Academy. Dr. Raj Singh and I, we are spearheading this as a resource, educational resource for our residence fellows. There are a lot of whole slide images archived under DAPA, and they're annotated, and we're building lectures around it. So it is truly a pleasure to share some information on bone tumor pathology, and hope you the best in learning pathology. And please be safe, healthy, and happy. Bye-bye.